Yes, we have Dr. Debasis Basu. I welcome him. Dr. Debasis Basu is a renowned diabetologist from Calcutta with over 32 years of experience. He is deeply respected by one and all in the diabetic care community. He has number of papers to his credits. His article on malnutrition in the Wall Street Journal 1997 resulted in almost $35,000 in donation for nutrition for preschool children. He also writes health column for the Telegraph, Saptahik Vartman, Statesman, and the Times of India. Assisted by his mentee Kiran Barhos, they are doing amazing work at Helios Global, which is downright a patient-centered organization and is doing a lot of community service. Thank you, Dr. Basu, for your presence over here.
I mean, I will. I had made a kind of a presentation ready because I was given to understand that Azad sir will talk about social part of the social determinants of health,
Yes.
and I would talk about the clinical part of it, and that's the reason I took the advantage. So I would go to my first slide, and I will quickly rush through because I was given to understand that I'm supposed to talk on, talk on pre-diabetes, and I don't know how you chose the topic, and it's so relevant to topic because the last gentleman who spoke as a patient was maybe could have been a person with pre-diabetes, but unfortunately he's not because his A1C was 14, and there is the role of the pharmaceutical industry coming. He is taking semaglutide 0.25 or zero point 0.5, and he should not be confused, or he should not be confusing a semaglutide, a GLP-1 RA, with an insulin. Now, this is the pharmaceutical industry. Semaglutide is naturally Novo. So Novo, or it's a local brand maybe in Bangladesh, they should have the prerogative to go and talk to him and tell him that this is a molecule which will keep away from insulin, actually. It's a ulta. So these are the four comments which are there from the biggest pharmaceutical houses that we talk about. So it's to help people do more, feel better, live longer. That's the pharmaceutical industry's finally, takeaway, mission. When the guy is standing in front of my clinic, a lot of them have queued up already. They will come to me not to, realize their salary at the end of month only, but to make sure that my patients are happy, I'm happy, and he's also happy to doing a commitment to society. So this is the slide that will get us from diabetes to pre-diabetes. We said life partner, diabetes. What the hell? We don't want diabetes as a life partner. So we actually will talk about pre-diabetes now. That is, let's say, prevent diabetes, or nip it in the bud. This is a state which is actually which is called a pre-diabetic state. This is a risk factor for developing into diabetes, and of course developing into all the other complications of diabetes. Unfortunately, in the world literature, it says 68%, 70% of primary care physicians don't identify these values as exactly what was done in her office as well. We would say roughly in India, Bangladesh, 90% of the primary care physicians don't pay heed to pre-diabetes. Now, what is it? This is how will we approach this case? We will approach in a person-centered care because this addresses a lot of multi-morbidity. We'll come to that later. We'll have a shared decision-making with the patient, with the patient's family members, the patient's, the friends, etc. And all these decisions will come into taking a particular course of action, whether we're going into conventional therapy or whether we're going choosing alternative treatment options. We are going to talk about the literacy part of the patient, the cognitive part of her understanding. Dr. Izam was talking about the SDOH, this social determinants of health, and there we will identify her economic status, the living and working conditions, the other domains like housing, education, the cultural values, how much practices of fasting, puja, etc. she does, and of course the socio-political context today. We have a lot of commitments elsewhere. Let us understand the type 2 diabetes natural history. So there is something called insulin resistance because there's so much of junk food, so much of pollution. We are the normal work that insulin does is it goes inside the artery or the wall of where the blood flows. It takes the glucose and it brings it and puts it on the cells where the glucose is absorbed or taken inside, and it is stored in a much healthier form. Now, if that doesn't happen, then the glucose is remaining in the blood. There is insulin coming to take the glucose inside, like policemen for taking the thieves and putting it at the jail or the cell of the jail. And the cell doesn't work because the cell is coated with all the polluted, maybe fat, and this lock and key mechanism doesn't open. So there is more sugar in the blood. There is more pump from the beta cell to secrete insulin, because insulin is secreted by sensing glucose in the blood. So the beta cells are stimulated, more insulin is released, and if they can now bring it to the cell back, then there is good sugar, normal sugar. But slowly with time, there is exhaustion of beta cells, and the insulin secretory defect occurs, and that gives rise to type 2 diabetes, where not only with the challenge of food, but also when you wake up in the morning, the fasting blood sugar also goes up. So more loss of beta cells, more you're going into diabetes. If you're taking, these secretagogues, these glimepiride, the glenides, then also they were squeezing the insulin, last bit of insulin that is there in the beta cells, and you are getting deprived of, the insulin. Finally, you are maybe having complete loss of the beta insulin from the beta cells, or the beta cells themselves die because there is no insulin release, but there is an amyloid which is taking up the space, like fibrils, like the Alzheimer's. You have these fibrils which take up the space of the beta cells, and the beta cells don't secrete insulin anymore, and you need insulin from outside. So it's no point, as the gentleman was talking to us, that dabda, the Elizabeth Kubler-Ross's dabda. You don't show anger to insulin. You don't bargain with insulin. You understand, get educated, and insulin as it is, like it's your savior in life. So the whole process of journey is, I'm saying normal now. My blood sugar fasting is, we talk in Indian terms, milligram per deciliter. In Bangladesh, just divided by 18. So it's, my fasting is 5 in Bangladesh, and my PP is 7. So I'm normal. But if my PP was, 9, then it would have been IGT, or impaired glucose tolerant, that is pre-diabetes. And that can progress to type 2 diabetes, and that can progress to, top to toe. Anything can happen. My hair cells can, grow gray. I can have skin problem. I can have retina problem. I can have stroke. I can have periodontitis. I can have lung issues, which our Corona Masi, 2 years back, she came and showed that how she's fond of the diabetic lung, the heart, the kidney, the sexual function, the toe getting amputated, top to toe, all happens with diabetes. Now, the question is, why are we interested in pre-diabetes? Because in pre-diabetes case, in this kind of a case where there's a predisposition of the genes, with the family history, that you can land up in diabetes, you better buck up, and you bucket those shows and see that you can really take a call on this. You will have good food, you will have a good amount of exercise, you will avoid all the bad habits, and you can stay out of diabetes. So this is the salvageable risk part, where almost pre-diabetes lead to 70% of them go to type 2 diabetes. But I can tell you the exact number can actually, if you try, go back to normal state as well. So that's the whole cry. The hue and cry is about this. So I will now tell you about, the intermediate hyperglycemia is a term which is used for pre-diabetes. And in 2009, they talked about this high risk status for developing diabetes. But what was talked earlier was borderline diabetes, sugar is a bit high, a touch of sugar. But this Tommy Thompson, he was the US Secretary General. He said in 2002, let us call this pre-diabetes. And since then, for brevity's sake, we choose this term pre-diabetes. These are all the historical anecdotes, how pre-diabetes came in, and how pre-diabetes is a precursor to heart disease. In 100 years back, this man was the largest man. This man looks like a normal policeman in the US and Canada now. So obviously, with obesity, we know the obesity is giving rise to insulin resistance. We know that almost 65 to 80% of all the diabetes in the world, type 2 diabetes, is contributed by obesity. We now know from new data, from BOM data, from WIDL data, that type 1 diabetes can also be contributed by the accelerated hypothesis of obesity. This is the prevalence. That in earlier days, we had high number of diabetes and then a small number of pre-diabetes. And unfortunately, the numbers are changing. because those pre-diabetes which was less, uh, which was getting more, are now quickly converted into diabetes. So now maybe you will get less amount of pre-diabetes number and more diabetes, because the conversion from pre-diabetes to diabetes is happening faster. So this is the fall. The fall in the IGT that you see is because of quick conversion from pre-diabetes to diabetes, which we hate to see. 11 years back, 12 years back, this was the data that almost 55% of the people in Asia, they were converting from pre-diabetes to diabetes. And that's the hidden danger we've all missed. The conversion rate, according to age, is this high. This is a very important data, that this data talks about the diabetes incidence by the fasting plasma glucose category. The take-home message is 50 to 60% decline in beta cell function happens when you put the patient on an OGTT, the 2 hours glucose test, 100 milligram per deciliter, when you see in the 2 hours sample, when you compare it to the 120 to 139, which is also normal, in 120 to 139, we assume that 50 to 60% of the decline in the beta cell has happened in that man. And unfortunately, you are still not defined as a person with prediabetes, because prediabetes definition, I will come to that later. This is the first phase of insulin secretion, which happens with food. I'm having some sweet. Within 10 minutes, my insulin comes to take care of that, with the sensing, it takes care of that sugar. That insulin is released from the beta cells by immediate signal that comes from the GLP-1 pathway. But next 2 hours time is a slow phase, but I'll give you this data. This first phase of insulin response is almost absent if your fasting sugar is more than 109. In this lady, it was 115, 117. So that 10 minute spike is not happening to put her sugar down for the next part of it when you go to the PP. When the fasting is 140, 75% of the beta cell function is lost, ladies and gentlemen. When fasting sugar is more than 180, there is a complete loss of fasting plasma insulin release, that phase. When 2 hours PP is more than 200, there is a marked reduction in FPI. Even in subjects with IGT, there is a marked. So not only in the fasting phase, but in the latter stage, when it is 2 hours, even if you have getting high numbers, that also is because the first phase was not working well. And the ticking clock starts very early. Now I'll run through the slides very fast, saying that this is the old Wikipedia's data, published in 1991. The old studies, came in the late 70s. Newly diagnosed diabetes in England, they were followed up, and the newly diagnosed cases had 50% of them had complications. They had retinopathy, they had ECG changes, they had absent foot pulses, they had decreased vibration sense, neuropathy, foot pulses absent is peripheral arterial disease. They had evidence of myocardial infarction on ECG, echo, and history of angina. They also had stroke and transient ischemic attack. So that is what we are now saying, that when you're detected or diagnosed for the first time, if you have 50% of the people, if they have so many complications, the ticking clock hypothesis says that it is a common soil hypothesis from where diabetes is diagnosed, and at the same time, all the other diseases are diagnosed, together. That is the tip of the iceberg. But when you actually now undermine and go inside the soil, in the common soil, you will have the pre-diabetes stage. Everything is also occurring in the same manner. Maybe not in that amplitude or magnitude. Maybe a person with diabetes can have a heart attack, 4 times than a person who doesn't have. But a person with pre-diabetes has the chance of having a heart attack, almost 2.5 times more than a person who doesn't have, pre-diabetes. So the definition that we need to understand, every one of us, is that in a fasting stage, our sugar should be, this is the number. It should be less than 100. It should be less than 100, that is 5.34 in Bangladesh. And our postprandial plasma glucose, which is, after a 75 gram glucose test, in the previous 3 days, we had a normal meal with at least 150 grams of carbohydrate. Then on the night before the test, we were without food for 8 hours, just only water, non-caloric, anything water is non-caloric. We do the glucose challenge test, and my sugar after 2 hours should be within 140. So that's something customary. That needs to be checked. That should be within 7. And if it is 140 to 199, then it is impaired glucose tolerant. If the fasting is 100 to 125, then it is impaired fasting glucose. And if the HbA1c is within 5.7 to 6.4, then it is prediabetes. If it is 6.5 and above, then it is diabetes. So diabetes is fasting blood sugar more than equal to 126. PP after glucose is more than equal to 200. HbA1c is more than equal to 6.5. These three criteria, which is the ADA age-old criteria that remain the same for all of us, this is what we follow, and this is to be mandatorily followed in order to do the right kind of judgment. Obesity is the order of the day, and we don't call anymore diabetes as only diabetes, we call it diabesity. And see, this is Professor Chittaranjan Yajnik, Azad sir's good friend and my mentor, and Professor Yatkin. They have the same BMI, but look at their body fat composition. Ranjan sir had almost 2.5 times more fat than Professor Yatkin. They used to work in Newcastle at the time. And this visceral fat is the precursor to metabolic syndrome and all the diseases that you have thought of. Prediabetes, whom to screen. So this is where the pharmaceutical industry can come in. These are the pointers that actually, make you come alive in the community and screen these people at that every nook and corner. You can take a kiosk in a mall, in a fish vendor's shop, wherever, in a mandir, in a masjid. If you can screen this population, you can really do a big major change for the country, because they can actually try to reverse and become normal, or even if they cannot manage to become normal, they will keep it as a pre-diabetes stage. So chance of heart attack is not 4 times, but 2.5 times. But if they fail and if they don't know, as I said, as we all know that India, Bangladesh, our undiagnosed population of diabetes is more than 55%. So if we can unearth this mystery, unravel the mystery, and say that, look, you have this problem.
Yeah, Shazia, you can proceed with the questions to Dr. Basu.
So yes, this is for you, Dr. Debasis Basu. As you and Dr. Azad also have been an expertise in the therapy area, there's something you have revealed which many brand managers and public may not be aware of. That is the role of dental and oral health in delaying pre-diabetic persons from becoming diabetic patients. Any thoughts on that? Any lights?
I showed you that slide. I mean, it occurred to Kiran one day. I mean, 2 years back, Kiran is with me with this company. She told me that we are doing a lot of education service. So she said, let's do something, this combination therapy area, we do some education. And we realized that the dentists, they do the procedures and the patients come back and the cases are not getting better. There's proper wound healing is not happening. They're going back. And maybe 1 month or 6 months down the line, they discover baseline diabetes or a pre-diabetes setting. And that may actually contribute, because if you've got a high A1C or uncontrolled sugar, your wound will not heal. So that, she developed the idea that we should do such a course. And in fact, we had this 4-module course with a pediatric and adult dentist and a diabetologist. And we realized that this course yielded, out of around 2,500 dentists, almost 25% of them now, I hear from them, they have got a glucometer in their clinic. For any procedure or before the procedure, they do a normal routine blood sugar check. And then if there's a problem, there's an anomaly they feel, they ask to go to get an A1C done. And finally, if it is high or whatever, on that basis, they take a call, they refer to a diabetologist, or my bottom line is they only do the procedure before they are happy with the sugar numbers or the glycemic control. So, whether it's a bad breath or whether it's a chewing difficulty, you don't have a tooth loss to start with, but they invariably land up in tooth loss. The young children, type 1 diabetes, if we don't take care of them as diabetologists, sending to the dentist, they will become edentulous. They will become so this is a very it's a bidirectional problem, and we need to actually empower the dentist to become actually the powerful first line, I say the first line catchment for getting diabetes under control in the pre-diabetes stage.
Oh, that's a wonderful insight, Dr. Basu. And I think many of the common people, they do not even know the relation between poor oral dental hygiene or oral hygiene and diabetes. But that's a wonderful insight which you have shared. Thank you very much.